Okay, good evening. Welcome everyone. We're going to get started right on time tonight. It's 7 o'clock, and we're so pleased that you've joined us here this evening. I'm Tammy Northam, Bladder Cancer Canada's Executive Director, and I'm your MC for this session entitled Non-Muscle-Invasive Bladder Cancer, a Spectrum of Disease with a Spectrum of Risk. We hope that you'll come away from tonight's webinar with a better understanding of your diagnosis, treatment, and future outlook, and some tips to help you along the way. Before we get any further though, we have a few housekeeping items to go over. First, to ensure the best possible audio experience for everyone, we have you all on mute in order to minimize the amount of background noise. While you'll be able to hear us speaking, we're not going to be able to hear you. So if you have a comment or question during the session, the best way to submit your question on a computer is to type it into the question box at the bottom of your GoToWebinar panel. If you're on a mobile device like a tablet or cell phone, click on the question mark icon. Please keep in mind that we will not be able to address questions that are specific to your case, but we will do our best to answer as many of the general questions as we can during the Q&A session following the presentation. If you find that you're experiencing technical issues, please send us a note in the question box and stick with us as we work to resolve the problem. Lastly, we are recording this session. So if you get called away or disconnected, keep in mind that you will receive the recording via email in the coming days. To help us understand the composition of our audience this evening, please respond to the poll that will appear on your screen any moment now. We'll give you 15 to 20 seconds to respond. Okay, we'll just give it a few more seconds here. All right, let's close that up. And we'll share those results with you. Okay, so it looks like 84% of you are a bladder cancer patient or survivor, 7% is a partner, 1% is a caregiver, and 9% a healthcare professional, and 4% other. So thank you. We're just going to launch one more poll now. Okay, let's see. And here's the second poll coming your way. So just a little survey as to where you're from. Collecting those responses. Okay, I'll give it one more second. All right, that looks good. We'll close that off and we'll share that out. And there you go. We've got 7% from Atlantic Canada, 9% from Quebec, 41% from Ontario, 35% from the prairies or the West Coast, and 7% other. So thank you. We'll move along here with our presentation. Okay. Great. So let's move along here, and we're going to just walk through some slides. There's me again. And I'm going to provide you with a bit of an introduction here about Bladder Cancer Canada. So just to give you a bit of an overview here, we are the first and only national patient-focused bladder cancer organization, co-founded by two patients 10 years ago now in 2009, Jack Moon and David Gutman. Our mission is threefold: to support patients, increase awareness and education, and fund research into bladder cancer. Who are we? Well, we're a national board of directors with 10 volunteers, patients and professionals, 1 full-time and 4 part-time staff, over 400 volunteers, and we have over 7,000 people registered with us to receive our newsletter. We also have a medical advisory and research board made up of 26 of the top specialists in bladder cancer, consisting of urologists, oncologists, and radiation oncologists. And they help us to advise on research and programs, review our materials, support our activities, promote us in their patient communities, and help us develop standards of care. And if you haven't seen this before, this is our bladdercancercanada.org website. We encourage you to check this out. There's lots of great resources that are credible and informative. Now we're going to talk a little bit about the first part of our mission, which is patient support. So we have what's called the one-to-one patient support program. So we receive about 200 phone calls or emails a year, and we distribute those out to over 40 peer support volunteers who are fully trained in providing support. We also have an online discussion forum with lots and lots of information, so we encourage you to check that out. And these support programs are run by volunteers, and there's 3 of them right there that are very important to us and help us out. We also host education meetings in various cities across Canada. We have 6 planned for 2019, and we also have a number of support groups across the country run by volunteers. So if you'd like to find out if there's one in your area, you can contact us or you can check our website for more information. And we also run live webinars just like the one you're on here right now. Our next one, part 2 of the series, is April 9th, 2019, from 7 to 8 p.m. with Dr. Michael Ong. The topic is how new immune and targeted therapies are changing bladder cancer treatment. And we have our guidebooks. We have 4 of them now. Formerly we had 3. We have a brand new book out on metastatic bladder cancer. So those are available to you for free and to doctors' offices across Canada for free to order. We also have videos on our website, and note that we also do post these webinars on our website for future viewing. So if you are madly taking notes, don't worry about it, because we're going to be posting these up on our site to be viewed over and over again. Second part of our mission is our public awareness programs. Most of you will probably be familiar with this very famous program, and you'll see that most of the artwork and advertising is donated and shown in these various avenues across Canada. But here's the exciting news. We have new creative in 2019. And so we haven't gotten rid of the lemon, but we've introduced a twist to the lemon, a little more shocking, but very impactful nonetheless. So the poster's being launched across Canada, and the video asset is coming in May. We also promote awareness among our patient community across Canada through help with over 40 volunteer community ambassadors. And our See Red brochure is placed in 1,700 GP offices through donated space. And we're always in need of new volunteers here. Bladder Cancer Awareness Month, promoted across Canada for the month of May, but this year we're having a year-long celebration in honor of the 10-year anniversary of Bladder Cancer Canada. So you'll see news coming out about that throughout the year. The third part of our mission is we do fund research. 5th most common cancer in Canada, yet 19th in research funding. So Bladder Cancer Canada is working hard to change this. And those photographs on the right are the last 2 grants that we funded through our own peer review program, the researchers that are conducting the grants. And finally, advocacy. So we work towards access to new and effective treatments, ensuring critical supply of drugs. We are the Canadian voice for bladder cancer patients, the one and only. We promote the right for a second opinion with patients or a referral to a specialist. We advocate for earlier diagnosis and early diagnostic screening. And of course, as mentioned before, increasing funding of research for bladder cancer. And finally, I wouldn't want to wrap things up without mentioning our awareness walk, one of our most critical fundraisers across Canada, but more importantly, bringing people together to connect, learn, and help make a difference. And our date for this year is September 22nd, 2019. We encourage you to visit bccwalk.ca, but it will not be live until May 1st. So if you're looking for information right now, you can go onto our website. And I wanted to just take a moment to thank our sponsors who assisted us in covering the costs of these webinars and making them available free of charge. So thank you to these organizations. Okay. So I'm just going to take a moment here to check my technology. And I'm going to ask Nick Power to join us on the webcam. And I'm going to introduce him right now. Dr. Power completed medical school and a urology residency at Dalhousie University in Halifax, and he became a fellow of the Royal College of Surgeons of Canada in 2009. He subsequently completed a urologic oncology fellowship at Memorial Sloan Kettering in New York City, where he trained with many of the world's leading urology cancer specialists. He trained in robotic, laparoscopic, and open techniques of managing urologic malignancies. Dr. Power is an assistant professor at the University of Western Ontario and is based out of Victoria Hospital. Dr. Power, thank you for joining us this evening. I'm just going to take a moment to turn you over as the presenter. All right, let's give this a moment, folks.
Great, I think we're all online here.
Awesome.
Okay. Great.
Okay, well, I'm just going to mute myself, but if you need anything at all, don't hesitate to ask, and I'll turn my mic back on. Okay?
Thanks, Tammy, and thanks
You're
to
welcome.
Bladder Cancer Canada for giving me the opportunity to come and speak with you tonight. It's a great honor. Bladder Cancer Canada is one of the few organizations that I deal with that has a truly altruistic goal. Their complete MO is to be there for the patients and to advocate for the patients, and it's really nice to have them there as resources for my patients when with a new diagnosis of bladder cancer. So it's an honor to be here, and I appreciate it, and thank you to Tammy and thank you to Carrie for helping organize this. So this evening, I'll be talking about non-muscle invasive bladder cancer, a spectrum of disease with a spectrum of risk. Non-muscle invasive bladder cancer truly is quite a heterogeneous and varied spectrum of disease. It goes all the way from disease that really does not risk your life up to disease that actually is life-threatening. And it's important as a patient and a caregiver to understand your risk so that you can best be able to make sure you go to the follow-ups for the cystoscopies and make sure that you're maximizing your chances of living free without this disease. On a personal note, bladder cancer of all types does affect a lot of us, and before I forget, I have to give a shout out to one of my family members who's, I believe, on the webinar this evening. When I was getting ready, my little boy said, shouldn't you tuck in your shirt? And I said, well, that's the good thing about being here is you don't have to tuck in your shirt. Besides, you can't tuck in a shirt when you're not wearing any pants. I'm just imagining all of you guys laughing because I can't hear you. But anyway, we'll be going through the presentation, and I'll just, if any questions come up, make sure you type them in, and I'll leave some time at the end to make sure we have a chance to discuss. So an overview, what are the basics of bladder cancer? What is the staging of bladder cancer? Those are really the important parts. When you're given an overwhelming diagnosis of cancer, you get sort of a crash course in the basics of bladder cancer and what things are important. When I'll be giving some advice towards the end of things that you should be aware of, but whenever you have a diagnosis of non-muscle invasive bladder cancer, you want to risk stratify. I'll be going through that. And then what is the treatment of non-muscle invasive bladder cancer? And the treatment really does depend on what risk category you fall into. When do you consider bladder removal in non-muscle invasive bladder cancer? I'll be going through that. And then what are some of the future potential treatments and diagnostic tests in the pipeline? An important part of non-muscle invasive bladder cancer is that it doesn't just affect the bladder. The cells, or the urothelium, goes all the way up into the kidneys, which is why it's really important whenever you're being investigated initially for bladder cancer, but also in terms of your follow-up, that you never forget about what we call the upper tracts. There is the same type of cells that line the ureters, the two tubes that come down from the kidneys, as well as inside of the kidney. Those do need to be surveyed along with your bladder. And not only that, the urethra can be affected as well. So all of these parts of your anatomy need to be surveyed quite closely in order to make sure that there's no evidence of any recurrence or progression. So what is bladder cancer? It's any cancer that arises from the bladder, mostly urothelial or transitional cell, which is what it's been historically called. For anybody who's looking on their own about resources, there are, sorry, just one sec here. There are transitional cell carcinoma in the past, and 90% of bladder cancer is urothelial. There are certainly other rare types, including adenocarcinoma, squamous cell, small cell, sarcoma. Even cancers of other kinds can metastasize or spread to the bladder. But for the most part, what we're talking about is urothelial carcinoma. Bladder cancer not only has a high incidence, it's the 4th most common in males and 5th most common overall, but it has a very huge burden on the healthcare system. Not only does even non-muscle invasive bladder cancer, where you have to be in visiting with your urologist on a very, very frequent basis, but on the other end of the spectrum, where people have advanced disease, the burden on the healthcare system is significant. And therefore, doing a better job at treating bladder cancer can certainly help all of us and our healthcare system. In the US, there are 74,000 cases per year. So what causes bladder cancer? The most common causes of bladder cancer are smoking. Smoking is by far the most important risk factor. There are certainly lots of people who are non-smokers who develop bladder cancer, but smoking is a major risk factor. In terms of occupational exposures, there are lots of people in various different industries, such as tool and die makers, working in the petrochemical industry, leather, printing industry, diesel engine exhaust. All of these things can increase your risk of bladder cancer. Sorry, just I'll do a pause there for 1 second. Not sure if you can see my whole presentation.
Hi, Nick.
Hi, Nick. Yeah, we're just seeing your first slide.
So if you click on the top there, top left corner, it says autosave. Moving to the right, oh, yeah. Moving to the right, there's a little, looks like a presentation screen icon along the top orange bar. You see that icon? There you go.
There we go. We see it now. Awesome.
Here now, okay. Perfect. In terms of other risk factors, anybody who's been exposed to chemotherapy or radiation in the past, perhaps for other cancers, does have a risk and increase your risk of bladder cancer. In addition to that, any physical trauma or irritation, and this does need to be chronic in nature, many years of infections or stones or instrumentation before you're at risk for bladder cancer. I updated our slide here that does show the new creative, but blood in the urine is really the most common initial symptom of bladder cancer. And blood in the urine can either be microscopic, meaning that your family physician does a urine test and identifies blood, or it can be macroscopic, where you can see the blood yourself. And either of those situations can be a sign of bladder cancer and should be investigated. Any other types of urinary symptoms are quite common overall, and there are lots of different benign causes of these, but taking together the symptoms in constellation with blood and urinary symptoms, it should be investigated. The vast overwhelming majority of people who are investigated for microscopic blood do not have bladder cancer. However, it is important to check. So how do we diagnose bladder cancer? Usually you're sent by your family physician to a urologist. A urologist will do a history, and we're trying to figure out your risks, if you have any occupational exposures, what your smoking history is. And smoking can be very distant. You can have a smoking history of 10 years, smoking 1 pack per day 30 years ago, and that can still increase your risk of bladder cancer. There is a brief physical exam, and we always like to do imaging because, as I said before, the urothelial cells line the entire urinary tract, so we do need to make sure that the kidneys and the ureters are okay, and that's done with either an ultrasound or a CT scan or MRI. And then finally, the test that a lot of people do dread is the cystoscopy. The cystoscopy takes about 5 minutes. I've really tried to find out from my patients how bad this is. Most people absolutely say that it's not as bad as they thought it was going to be. And there are various different ways that you can do to minimize the pain experience. It does take about 5 minutes to check things out. People are awake. There's no special preparation beforehand. And afterwards, you can carry on about your day as usual. There may be a little bit of blood, and there is a slight increased risk of infection. But if you drink lots of fluids after your scope, then that can usually minimize any complications. If we diagnose a bladder tumor, usually we can see that with the scope. It's always a bit of a difficult conversation because you take somebody who is worried about something going on in their bladder, and then you take them for a cystoscopy and you identify something. It is always a very difficult situation because you recognize that this is your patients are put in a very vulnerable position, and there are lots and lots of questions, and it's really difficult to answer all of them initially. And the reason why is that it does depend. If we find a tumor in the bladder, we don't really know what the grade or what the stage of it is. And so the first step in really risk stratifying and identifying your risk is doing what's called a transurethral resection of bladder tumor. And we do that in the main operating room. We do that under general anesthetic usually, and it uses electricity on the end of a little loop. There's no cuts on the outside. We do it all through the scopes, and we essentially scrape away the top part of the cancer, and then we go deeper into normal tissue to make sure that we get a good idea of how deeply the tumor is growing. Once we have that information, then we can better be able to say what the next step should be. When the pathology report does usually come back from these specimens within 1 to 2 weeks. There's a push across Canada to prioritize bladder cancer to make sure that the pathology does come back in a quick time frame so that subsequent treatments can be planned. And what the pathologist will tell you when they look under the microscope is how deeply things go into the layers of the bladder. And you can see from this diagram that as you go up in terms of your T stage, it goes deeper into the layers of the bladder. TIS, which is in situ carcinoma, is only in the first layer. Now, as a general rule, the greater the T stage, the greater the risk is. However, carcinoma in situ, which is in the very first layer, is actually one of the higher grade lesions. What we're talking about this evening is all T1, TA, and TIS. The T2 is essentially into the muscle, and the categories of non-muscle invasive bladder cancer are essentially the ones before T2. CT scans are important when you get a diagnosis of bladder cancer. Again, that does depend on the stage and the grade. The higher stage and higher grades need CT scans. If it is low grade and really small tumors, then often you don't need full CT scanning. Often an ultrasound is good enough. For non-muscle invasive bladder cancer, so this represents the most of bladder cancer that patients will experience and that urologists will see on a regular basis. So most of these tumors are superficial, 75% of them are non-muscle invasive. The very, very important thing when you're dealing with non-muscle invasive bladder cancer is assessing your risk. And the risk comes in two forms, really. It is the ability of the cancer to come back, which is recurrence, and then the ability of the cancer to either go deeply into the layers of the bladder or to change from a lower grade to a higher grade tumor. The risk factors involved in non-muscle invasive bladder cancer that really dictate what your chances of recurrence are or what your chances of progression are well established, and they're well established from numerous guidelines. They depend on the grade of the cancer, which is what the cells look like under the microscope, the stage, how deeply it goes, multifocality, is there one tumor or are there multiple on different sites of the bladder? The size, usually 3 centimeters is the general rule, less than 3 centimeters versus greater than 3 centimeters. And then if there is any associated carcinoma in situ, which tends to increase your risk of both progression and recurrence. The title of this presentation is a spectrum of disease and a spectrum of risk. And many people aren't that familiar with bladder cancer, but they are familiar with skin cancer. And I often will tell people that it's kind of like skin cancer. The low-grade tumors, they have a very low chance of spreading or risking your life, and that's similar to the sunspots or the basal cell carcinoma that many people are familiar with. Whereas the higher grade lesions, the carcinoma in situ or the high-grade T1s, those are kind of like melanoma, where they do have the risk of spreading and they do have the risk of being life-threatening. And therefore, understanding your risk and understanding how your risk really affects you is really important. So I'll just pause here for 1 second. So risk stratification is very important. It is one question that you should absolutely ask your urologist whenever they diagnose a bladder cancer, is ask them what your risk is. all guidelines from around the world stratify according to low, intermediate, or high risk. And depending on the types of tumor, what looks like under the microscope depends on what risk you'll fall into. So the low risks are the ones with the small single tumors. They're the low-grade type. They don't look aggressive under the microscope. Intermediate has multiple tumors, but again, they don't look aggressive under the microscope. And high-risk patients, high-risk tumors, they look aggressive under the microscope, and even if only a few layers, either the TIS or the T1 or TA. So again, when you get your risk, you can ask your urologist or treating physician, what's my chances of recurrence and what is my chances of progression? So recurrence is the tumor coming back, and the risk of recurrence will dictate how often you'll need to be surveyed and what types of things you'll need for surveillance. In addition to that, on top of the resection, you may need additional treatment on the inside of your bladder to reduce not only the recurrence, but also the progression. So recurrence, low-grade, non-invasive tumors, they do have a risk of recurrence, but they have a less chance of progression. Whereas progression from non-muscle invasive to muscle invasive disease are those tumors that have high-grade carcinoma in situ or T1 staging. You can see here, this is from one of the most commonly cited references looking at recurrence and progression. You can see the risk groups along the left-hand side of the slide, and then you see what your 1 year and 5 year risk of recurrence and your 1 year and 5 year risk of progression. So look, taking an example for a low-risk tumor, a solitary low-grade tumor, your chances at 5 years of finding something is about 30%. And so that's why it's really important, even with the low-grade tumors, to be in for your cystoscopies on a regular basis. But you can see here, it's less than 1% that any of these tumors ever do progress to needing more radical or aggressive treatments. Intermediate risk, which is the multiple tumors, but still of low grade, they do have a higher risk of recurrence, sometimes up to 50–60% at 5 years. But again, the progression is relatively low. At 5 years, it's 6 to 17%. The high risk group is really, really important. High risk non-muscle invasive bladder cancer is a disease that can almost put you into a situation of complacency, because you go through the diagnosis, it's a scary thing, you get treated, and everything's fine. Things look normal on the inside of the bladder, and you're free. But the chances of it coming back at 5 years are 78%, and the progression to muscle-invasive disease at 5 years is 45%, or almost 50% of people. So that's why it's always important to know what your risk is. That will dictate how often people are looking inside of the bladder or ordering CAT scans. And to cut your risk of recurrence and cut your risk of progression, we usually add things onto the inside of your bladder, which I'll talk to in a second. There are numerous guidelines, Europe, Canada, the US, various different, the UK, they all have guidelines that are published. And Dr. Ozawa, who's part of the Medical Advisory Board for Bladder Cancer Canada, and I wrote a comparison manuscript, and all are in general agreement with some minor variations. You can look to these guidelines. There are patient-friendly versions of these, but some of the questions that may come up are, what are the latest and greatest type things? And you won't necessarily find much in the guidelines about this. And the reason why is that for any of these newer treatments, they need to have and raise above the threshold of being evidence-based and well-researched and safe before they reach a guideline. And we'll get into that in looking into the future directions. So the most important types of treatment to reduce your risk of recurrence and progression are the medicines that we put on the inside of the bladder. There are a few that you can consider. BCG is one of the most important tools that we have to reduce risk and reduce your risk. BCG is attenuated mycobacterium virus. It really was an unusual finding. Dr. Morales, who was from Quebec, did some of the pioneering studies back in the 70s and 80s and really found that BCG, for some reason, that we don't even really fully understand to this day, reduces the risk of bladder cancer. And it works in a way that modifies the immune cells within your bladder to make it more inhospitable for tumors to grow. It is a very important strategy that we still use to this day. There are also other types of medicines we put inside the bladder. We use mitomycin C and epirubicin, and also gemcitabine. There are lots of different treatment options, and again, looking at your risk of recurrence and progression depends on when you potentially use these different agents. So BCG does reduce the risk of recurrence and progression. It's generally very well tolerated. There are some common minor side effects. You can get some cystitis, which is some irritation of the bladder or pain when you pee, frequency and urgency of urination. You can get a low-grade fever. There's a risk of urinary tract infection. There's also a risk of causing infection in either the testicles or epididymis or prostate. There are rare serious side effects, less than 1%, but overall it's very well tolerated. And when you receive BCG, usually you go in and it's once a week for 6 weeks. This is called the induction phase of the BCG. And a catheter will go into the bladder, and then the medicine is delivered into the bladder, and then the catheter is removed. And then you keep that within the bladder for as long as you can, at a minimum of about 30 minutes. And then you pee it out. And it's usually extremely well tolerated. There are lots of things you can do to reduce your chances of having any complications. Often if you take some Tylenol beforehand, you make sure that you're not having any infection symptoms, then that will really help. Depending on your risk will then dictate what your follow-up schedule is like. So looking at low-risk tumors who don't have the risk of progression, but do have the risk of recurrence, you need to follow people usually for about every 3 months after the first resection, and then annually beginning 9 months after the initial surveillance. You can consider stopping at 5 years or more, but this does depend on how comfortable you are with the risk and how your urologist deems your risk to be. You don't necessarily need upper tract imaging unless you do have episodes of blood in your urine, which is very different from the intermediate or high risk. You need any recurrence, you need imaging for blood, but also for the high grade tumors, you need upper tract imaging annually for 2 years. And this is often something that gets missed because doing 3 months scopes for the first 2 years, it's sometimes difficult to remember to do this. And so taking responsibility for that and asking your urologist, do I need to have any upper tract imaging, an ultrasound or a CAT scan, can help out your urologist in trying to manage your risk. Another important part is that all of these clocks do restart with each recurrence. So anytime you have a recurrence, the clock starts again and you reset everything. To prevent recurrences, there are actually things that you can do. There are lots of studies to suggest that those patients who continue to smoke while having a diagnosis of bladder cancer do tend to do the worst. They tend to have worse progression and worse recurrences. And so trying to stop smoking altogether or even cutting your smoking down will help. If you can identify any occupational exposures and avoiding them, that's important. Dietary modification and physical activity, it's hard to make a direct link to these things, but anytime any study has ever been done with eating more fruits and vegetables, minimizing your red meat intake, also increasing your physical activity, it's all anti-cancer. And so these are types of things that you certainly can do that will reduce your risk. I'll mention briefly about cystectomy. Cystectomy is the other end of the spectrum where we offer this very commonly to people who have bladder cancer that's gone into the muscle. And it is considered quite a radical therapy that does certainly affect people's quality of life. When you remove the bladder, you also remove the prostate and the lymph nodes. In females, you also take out the ovaries and fallopian tubes and uterus, as well as part of the vaginal wall. So it's quite a big surgery and takes a long time to recover from, but it is life-saving in many patients. There are various different forms of diversion, so how you divert the urine. The ileal conduit is the most common. Indiana pouch is rarely done these days in a neobladder. You can see here the various different parts of the bowel that we use to reconstruct on the inside. An ileal conduit takes a small piece of the bowel and brings that out to the skin, and then connects the two tubes from the kidneys. There are lots and lots of questions when I take people through this, trying to decide if it's right for them. And many people will worry about their quality of life afterwards. Essentially, anything you can do today without an ostomy, you can do afterwards. People can run, be active, even swim. There are lots of different things on the market that will help people keep very active. And so while it is a change in the quality of life, if it's life-saving and needs to be done, then people will choose it. The Indiana pouch is a catheterizable stoma where you essentially, this is continent at the skin, and then you insert a catheter when you need to empty the pouch. This is less commonly done because there are lots of complications that can occur, and very often people, if they want something continent, will go towards what's called a neobladder. The neobladder is where we recreate a new bladder on the inside of your body, where ultimately you don't have to deal with the urostomy appliance and the bags and things, but certainly takes a long time to recover from, and there are lots of things that can go wrong with this. So speaking to your urologist about the various different forms is important. There are new technologies that are coming down the line. One of these is electromotive drug administration, and this uses mitomycin C, and it pushes the mitomycin C into the bladder wall. Essentially, you put the mitomycin on the inside of the bladder, and then you run an electric current. You can see this on the right-hand side through the bladder, and that pushes it in. I say that this is a new technology, but it's actually been around since the 90s. Only recently has there been newer trials that have shown that there may be some improvement in reducing people's risk of progression and recurrence with doing it this way. It's certainly small trials, and it hasn't reached the prime time, and many of the guidelines across the world have not recommended this as a standard treatment option, but in highly selected patients, it can certainly be the right choice, particularly if you're trying to reduce the risk of recurrence and progression. There are various different ways that you can follow people. One type is cystoscopy, and on the left-hand side, this is white light cystoscopy, what usually is done. And you can see that the tumor that's in the middle here is a little bit less well seen. Now this photograph is taken from the people who make the CysView, and you can see here that you install a chemical and it really lights things up. But actually this view on the left-hand side, white light cystoscopy, and the video images that we get today are extremely good. Blue light cystoscopy does offer some slight advantages, again, in highly selected people, but right now, white light cystoscopy is considered the standard of care, and most of the times the blue light cystoscopy is picking up lower grade recurrences and that don't often are not a risk to your life. There are lots of new drugs on the horizon. This is just a brief slide looking at some of the trials that are out there. These trials are using checkpoint inhibitors, so pembrolizumab, atezolizumab, durvalumab. All of these ones are trying to use your own immune system and harness its anti-cancer abilities so that you can cut both the recurrence and the progression risk. There is nothing right now that is a standard treatment option in terms of the checkpoint inhibitors, but there are lots ongoing. So in summary, it's very important whenever you get a diagnosis of non-muscle invasive bladder cancer that you understand your risk. What is your risk? There are numerous options for treatment depending on that risk. Proper staging and counseling at each step is of paramount importance. At each step that something changes, you reset the clock, you reset your mind frame and you're thinking about this, because ultimately you want to reduce the risk of recurrence and reduce the risk of progression, and ultimately keep this disease at bay. Early cystectomy, and the reason why I mentioned it in this presentation, should be strongly considered. And if you have aggressive disease that is showing itself that it's not going to be stopped by BCG or any of the things that you're throwing at it, considering radical therapy may be the best decision. And certainly those are tough decisions, but ultimately curing the cancer is the goal. There are future diagnostics and drug therapies that are still being investigated, and these do show up on the market every year. We do see these things coming down the pipe. So to close, there are some advice that I would give to you out there. Whenever you go in, particularly in the early stages when you're trying to understand what's going on and what your risk is, it's always important to bring an extra set of ears, write things down. I know that of any of the urologists that I know, we want people to be informed and we want people to ask questions. It's only then that we can really counsel people appropriately about the risk and inform them of the decisions. It's often better because it's when you get a diagnosis, it's a lot of information all at once and it's really hard to make decisions. So don't feel pressured into making a decision right away. It's often better to make another short-term follow-up, maybe in a week or two, to discuss what the decisions are and to clarify any questions so that you know what decision is right for you. It's within your full right to obtain copies of reports, and then once you get the copies, look through them, write down any questions that you might have about them, and clarify them the next time you're in with your urologist. Understand your grade and stage, and subsequently your risk. You always have the right to gain a second opinion, and if you don't feel comfortable with asking your urologist, you can always ask your family physician to refer you for a second opinion, or you can be in touch with Bladder Cancer Canada, who can often help in this regard. I begrudge no one who asks for a second opinion in my practice. This is your life. This is a disease that can be life-threatening, and we want you to make the right decision. We want you to be confident and comfortable in the decision you're making. And only then can you really move forward and try to put this in perspective with the rest of your life. It's really important that you take responsibility for the follow-up tests and scopes. You should be, if you haven't seen your urologist in a while and you wonder why there isn't any scopes, call them up, and things may have fallen through the cracks, or you may have not have gotten a letter in the mail. It's really important to do that. So with that, I will again thank you for your attention, and happy to answer any questions.
All right. Thank you, Dr. Power. Wonderful presentation. So at this point in time, we are going to, we've been taking in questions throughout your whole presentation, and Carrie is going to come on board with us on her mic to take some questions from the audience. But first, I'd like to remind everyone that you can still ask questions as we go, and the best way to do so is in the question box on the go-to panel on the right side of your screen. Again, Dr. Power cannot answer questions related to your specific case, so please try to keep them as generalized as possible. So, Carrie, have we got you on the line here?
Yep, can you hear me? Can you hear me?
Yep.
Great. I'm just going to shut off the audio on my phone here. For some reason, I thought it was off. Okay, so first of all, hi everyone. It's great to see so much interaction here on the back end. There's a lot of questions coming in. Unfortunately, we have a lot of individual questions about individual cases, so we can't necessarily address those. I'm trying to generalize some of them as much as possible. I guess one of the first ones that comes to mind is regarding inflammation. I'll just read it out. It says, is it normal to see inflammation at the spot from where a tumor was removed after BCG treatment? If so, how long does it typically take for that inflammation to go away? I'm sure there's no exact answer, but generalities,
Yes.
what's to be expected?
So it's a really great question, and one that the one that we struggle with all the time. You put somebody through a scraping of the bladder, which causes a scar in the bladder, and then if it is higher grade disease or carcinoma in situ, you put people through BCG. BCG induces an inflammatory response, which is essentially how it fights the cancer. And you can get what are called granulomas. Granulomas are essentially scar tissue within the bladder, and this can be quite common. So when you look inside of the bladder for surveillance after the BCG, you very often see these things, which is why very often we need to use additional tests to make sure that this isn't areas of carcinoma in situ or recurrence. So the urine cytology, which should be taken every time we do a cystoscopy on you, will really help. They've done a lot of work to try to improve the accuracy of this so that there's a lot less atypical type of urine cytologies out there, and it erases a lot of the unclear evidence. So making sure that the urine cytology is negative and the way that things look on the inside. BCG continues to work for quite a long time after the last medicine goes in the bladder. So we see lots of patients where they have residual positive cytology that if we wait a bit longer, then that will turn negative. So asking your urologist about what the cytology is, making sure that there's no infection with the urine study is important. But as a general rule, if somebody has had BCG, it takes about a year before things look 100% completely normal inside the bladder. You can always find some inflammation, irritation, which is why it's important to follow up so regularly.
Okay, thank you for that thorough response. Another question is, are there long-term adverse effects to BCG?
So we've been using BCG for somewhat 40 years now, and so we have a long experience with this medicine. Again, it's been highly effective at improving patients' lives. In terms of long-term effects, usually only in the people who have quite intolerable side effects. There are some people who don't tolerate the BCG. Either their bladder is too irritated from the medicine, or they have other reasons why their bladder is not functioning well, so that ultimately the BCG can occasionally make these worse. And so the frequency, urgency, irritation type may not be 100% caused by the BCG, but it can make things worse in the short term. In terms of long term, looking at reactivation of TB, essentially that's what the BCG is weakened TB. There's been no long-term side effects in terms of reactivation of this. It's usually over the short term where things occur.
Okay, thank you for addressing that sensitive topic. And I think, unfortunately, we had a lot of questions streaming in the last few moments, but we've run out of time. So I guess, Tammy, take it away.
All right. So thanks, Dr. I guess now with 2 minutes remaining to wrap things up here. I'm just going to give myself a better view there. Okay, I'd like to again extend our sincere appreciation to you, Dr. Power, for joining us this evening. You do such an incredible job of delivering information about bladder cancer that is easy to understand, and it's because of caring and generous professionals like yourself we're able to offer sessions like these at no cost to our community. I'd also like to thank the rest of you for being with us this evening. We hope you gained some new information and that can be applied in your own situation. Please be reminded that we will be recording this, and we'll be sending you a feedback survey over the next couple of days. So please take a few moments so we can continue to improve these sessions. But should you find that you need information or support of a more general nature at any time throughout your treatment and your journey, please keep in mind we do have our one-to-one peer support volunteers who are trained and available to support you. So just call or email us. We also encourage you to join our online discussion forums and to subscribe for our newsletter at bladdercancercanada.org. And lastly, we invite you to volunteer with us if and when you're ready. There are many ways in which you can help us to fulfill our mission to support patients, increase awareness of bladder cancer, and fund research. Wishing you well this evening, and please stay in touch.